This is part 2 of our cardiovascular emergencies lecture series. In part 1, we talked about acute coronary syndromes, the assessment and management. In this part, we're going to talk about heart failure. In this section, we're going to, just so you're aware, we're going to talk about left ventricular failure and right ventricular failure. Remember that your heart is essentially two pumps that are connected, one on the left that provides blood oxygenated under high pressure to the body, and then the other, the right side, that sends deoxygenated blood to the lungs where it's going to be reoxygenated so that it can go back to the body. Okay, so heart failure occurs when the heart is unable to pump powerfully enough or fast enough to empty its chambers. This results in backflow of blood into the systemic and or pulmonary circuits. It's characterized often by volume overload and inadequate tissue perfusion. Okay? Some of the common features include fatigue, dyspnea, edema, and exercise intolerance. Okay. Some of the causes of heart failure: coronary artery disease, right? If you can't perfuse those coronary arteries, then the heart muscle is going to be damaged. Long-standing hypertension, which causes an enlargement of the ventricles, diabetes, and dysrhythmias. Others, cardiomyopathies, okay, damage to the muscle of the heart, valvular heart disorders, so the valves aren't working properly, and then genetic conditions, okay. Contributing factors include thyroid disorders, whether it be hypo or hyperthyroid, alcohol abuse, cocaine, and abuse of other substances, cancer treatment, and then some infectious agents, which we will talk about at a later point in our lecture series. All right, heart failure can be classified a few different ways. It can be classified as acute or chronic. It can be classified as left or right-sided. It could also be classified as systolic or diastolic. Okay, so is it a problem with squeezing or a problem with filling? Okay, heart failure is impaired cardiac output. So remember that cardiac output, right, is equal to heart rate times stroke volume, right? So any condition that negatively impacts cardiac output is going to potentially lead to heart failure. So if the heart rate is too low, right, cardiac output decreases. Remember that stroke volume is made up of preload, afterload, and contractility. All right, so if the heart does not fill well, that's poor preload. If there's not enough blood in it, when it squeezes, right, less blood comes out, and that would decrease cardiac output. So things like low blood volume would decrease preload, or conditions where you're very vasodilated, like sepsis, would decrease preload. Afterload is the resistance that the heart has to overcome for blood to exit. So your left ventricle, for example, right, if your systemic blood pressure is like 280 over 160, the left ventricle has to squeeze really hard to get blood out against that pressure. So you would have high afterload. That high afterload would decrease cardiac output because the heart can't contract that forcefully over that pressure, and so you'd actually have decreased cardiac output and stroke volume. And then contractility is the force of the squeeze. Okay, so if a patient had like a heart attack that affected a large portion of the ventricle, that portion is not going to contract well, and when it doesn't, the cardiac output suffers. So anything that negatively affects heart rate, preload, afterload, or contractility, decrease in heart rate, decrease in preload, increase in afterload, or decrease in contractility. Okay, any of those things. All right, your left ventricular failure is going to cause blood to back up into the left atrium. So if we're looking at our picture here, we're down here in the left ventricle, right? If the left ventricle fails to put blood out, right, then more blood is going to hang out in the ventricle, and eventually that ventricle is not going to be able to handle it, and you're going to get back pressure into the left atria, and then back pressure into the pulmonary arteries, right, and then into the lungs themselves, right? So we end up with fluid in the lungs, right? All right, so left ventricular failure is going to cause the backup of blood into the left atrium. Then it's going to back up into the pulmonary circulation, pulmonary circuit, pulmonary system. And those high pulmonary pressures are going to cause fluid to leak out of the vasculature and into the alveoli, leading to pulmonary edema. Okay. All right, left ventricular failure can be classified as systolic, which means that the squeeze is poor. So think the patient who's had a massive heart attack, now a bunch of that tissue is dead tissue, or is infarcted, right? And that tissue is not going to contract. Scar tissue also does not contract. This is going to lead to a weak squeeze, okay? You could also have diastolic heart failure. So this is when the ventricle either gets stiff, and doesn't relax, or the ventricle lumen gets really small, right? So if we think about the ventricle kind of looking like this, right? If the ventricle can't stretch, then it doesn't fill very well. If it doesn't relax, right, then it's not going to stretch well. It's not going to fill very well. The other thing that can happen is that the muscle can actually thicken, right? And now the space that's there for filling as this muscle thickens, right, gets smaller. Okay, so still, again, a lack of filling space or filling stretch or relaxation is going to lead to diastolic failure. Some of the causes: uncontrolled hypertension, right? So if I go to the gym every day and I start lifting weights, my muscles are going to get bigger. Well, if my blood pressure is high, right, constantly, then my left ventricle is going to get big, right? And we're going to reduce the space for filling, okay? Other causes: tachydysrhythmias, okay? So the patient's got a fast heart rate, okay? The problem with fast heart rate is that the heart doesn't get time to fill. It's a rate problem, but the rate part of the equation, right, that cardiac output is equal to heart rate times stroke volume. The rate technically should increase cardiac output, but it doesn't, because these tachycardic dysrhythmias cause a decrease in preload, okay, because there's less time for the heart to fill. Okay. Other causes: coronary artery disease, or MI, which we've mentioned already. Like if you can't perfuse the tissue, then the muscle will not work, right? And then volume overload, right? So if I put two 16 gauge IVs in you and I dumped, an additional, 4 or 5 liters of fluid on top of what you already have, eventually your heart's not going to be able to handle that much volume, right? It can't. And that's going to lead to failure of the ventricle. Okay? Can't pump over that pressure. Okay, so when we think about what happens, right, for whatever reason in left ventricular failure, whether it's systolic failure, diastolic failure, or the underlying cause, whether it's an MI, prolonged hypertension, whatever the case, eventually the left ventricle doesn't empty appropriately. Okay, so it may get weak, but it cannot empty appropriately. And as a result of the left ventricle not being able to empty appropriately, you get a decrease in cardiac output, okay? With that decrease in cardiac output, you expect to find activity intolerance and signs of decreased tissue perfusion, right? So every time I go walking, I feel like I'm weak, I'm tired, I can't catch my breath, right? So decreased tissue perfusion, activity intolerance. You're also going to end up with decreased perfusion to the kidneys. Now remember what I told you before, that the kidneys are oxygen and pressure sensitive. Okay, so if I decrease perfusion to the kidneys because my cardiac output has decreased, my kidneys are going to release renin, right? And we're going to get that renin, angiotensin, aldosterone system activation, right? So remember that renin meets up with angiotensinogen, right? And that forms angiotensin 1. And then now angiotensin 1 is floating around in the blood. It moves itself around to pulmonary circulation. It finds ACE, or angiotensin converting enzyme, which converts angiotensin 1 into angiotensin 2. Angiotensin 2 is going to cause vasoconstriction. It is also going to cause the release of aldosterone, which is going to cause salt and water retention. You're also going to get antidiuretic hormone that's going to be stimulated, which is also going to cause salt and water retention. Okay, so renin-angiotensin system is going to be activated. As a result, you're going to vasoconstrict and get salt and water retention. Well, we can't handle the volume we had, or the left ventricle wouldn't be failing. But now, because we've increased the volume and the pressure that the left ventricle already couldn't have or couldn't handle, blood will back up into the pulmonary veins, right? So now we got blood that was in here, right? It's going to back up into the left atria, and then it's going to back up into the pulmonary veins, and then it's going to back up into the pulmonary capillaries, right? And blood will leak out of the pulmonary capillaries into the lung tissue itself. This is going to lead to, whether it's in the interstitial space or actually in the lung itself, it's going to lead to impaired gas exchange. And then as a result of poor gas exchange, right, you're going to have possible cyanosis and other signs of hypoxia, okay? So signs of hypoxia, right? So shortness of breath, for example, right? Cyanosis, altered mental status, right? You will also get pulmonary, so this is going to lead to that pulmonary edema, right? I want to tell you that where they talk about pink frothy sputum, yes, your patient may be coughing up pink frothy sputum. They like to test on pink frothy sputum. More often than not, when I have seen pink frothy sputum, it's been coming up of an ET tube when a patient's intubated and in cardiac arrest. So yes, it's a sign of left ventricular failure. It's not as common as the other signs, right? So some of these signs are paroxysmal nocturnal dyspnea, which means I suddenly wake up at night and I can't breathe, right? Orthopnea, I won't lay flat, okay? So those are some other signs, right? And then all of this, right, is a feedback loop that's not going to stop, right? So now we have impaired gas exchange, we have shortness of breath, we have a left ventricle that is being asked to work harder because we retained salt, we retained water, we increased pressure, and it can't do it. So the left ventricle gets even weaker and still can't empty. And then you can see that this is a self-perpetuating loop. Okay, so what are some things that could help a patient get out of this loop? Well, what if we interrupted this? What if we gave a patient like an ACE inhibitor? Could that help? It could, right? So there's some care that we'll talk about later, but that's one of the medications that these patients may be on to interrupt this loop, because otherwise heart failure doesn't get better, it will only continue to get worse. Okay. All right, moving on, we talked about left ventricular failure, we're going to talk about right ventricular failure. Okay, so in right ventricular failure, here's your right ventricle, right? The right ventricle gets weak, okay? It can't empty fully, and blood will begin to back up into the right atria, okay? Then when the right atria can't contain it, it's going to back up into systemic circulation, which is your body, okay? All right. This is going to lead to increased venous pressures and increased capillary pressures, and it's going to cause the leaking of fluid into your peripheral tissues. So things like swelling in the legs or ascites in the abdomen, right? Sacral edema. Okay, these are things that you would see. JVD, right? Remember that your jugulars are like right up here. So in the acute setting, JVD is probably going to be first, right? In the chronic setting, you're probably going to see some of these others, okay? But the patient who's having a massive right-sided MI, they called you 10 minutes later, right? As soon as they started having chest pain, you show up 10 minutes later. They may have JVD, but they may not have other peripheral signs because, you know, distance. So. Okay. Right ventricular failure can be caused by a few different things. So isolated right ventricular failure is going to be common in things like a pulmonary embolism. So in a pulmonary embolism, a clot gets stuck in the pulmonary arteries, right? So in the pulmonary arteries, blood can't get past that clot and it backs up into the right ventricle, right? And so the right ventricle is not going to be able to handle that and it's going to back up into the body. An isolated right ventricular infarction, so an inferior wall heart attack, or not inferior wall, but a right coronary artery that's occluded is going to affect the right ventricle. Okay, and then pulmonary hypertension, so high pressure in the pulmonary arteries for other reasons. Sometimes it's congenital, but it also could be due to like a PE or something, or COPD, something like that. Okay. We call right ventricular failure when it's due to pulmonary disease cor pulmonale. So just so you're aware, when they talk about cor pulmonale, they're talking about right ventricular failure that's specific to a cause of pulmonary disease. So think about your COPD patient, right? They got really bad COPD, they're hypoxic all the time, right? The kidneys are very sensitive to, we said pressure, but also to oxygen. So now their oxygen levels are chronically low. So they increase the number of red blood cells they have. The kidneys are going to release erythropoietin. You get an increase in red blood cells. Now the blood becomes viscous. Well, the right side of the heart is not designed to handle high pressure, right? And viscous blood is harder to pump. So now the right ventricle is having to pump this thick blood through the pulmonary circuit, not designed to have to work that hard, and that can lead to right ventricular failure. However, the most common cause of right ventricular failure is left ventricular failure, just so you're aware. Left ventricular failure is the most common cause. When we look at our graph of how this works, right? Instead of starting with the left side, we're going to start with the right side. The right ventricle, it empties, or it weakens and it can't empty fully, which is going to lead to decreased cardiac output. So remember, the right ventricle, this is really important for you to understand, fills the left ventricle. Okay? So when the right ventricle cannot empty appropriately, right, then less blood gets to the left side. Okay? Less blood gets to the left side. When less blood gets to the left side, you have less preload. Okay? So it's responsible for left ventricular preload. Okay? So the rest of this graph is going to start looking pretty similar, right? So we get a decrease in cardiac output, right? Because there's less preload on the left side. When there's less cardiac output, the kidneys start doing their renin-angiotensin thing because they sense that decrease in perfusion. Renin-angiotensin-aldosterone system is activated. We get that salt and water retention, and then we get backup of blood in the systemic circulation into the vena cava and into the periphery. Okay? You get increased venous pressures, which result in edema in the legs, the liver, and abdominal organs. Okay? And then those high venous pressures also cause neck vein distension, or JVD, and they can also lead to cerebral edema. But again, this process doesn't get better, right? It only gets worse because we're still got a weak ventricle. We've kept more salt and water, which we couldn't pump before, so now we have more volume and a weaker pump, right? So the right ventricle is still weak and can't empty. Cardiac output decreases further, and we get this self-perpetuating loop. So it's got to be interrupted somewhere if we want to stop the failure that's occurring. For heart failure, your body has a compensatory plan. The plan is that it's going to manipulate preload, afterload, contractility, or heart rate to improve cardiac output. Okay, so when your heart starts to fail, you get things like sympathetic stimulation. So epi, norepi get released. That's going to increase the heart rate. It's going to increase contractility. It's going to increase systemic vascular resistance. You also get, like I told you before, that renin-angiotensin system, which is going to increase systemic vascular resistance. Remember, SVR is the contractility of the vessels, how tight the vessels can get, right? Vasoconstriction. And it's also going to increase intravascular volume because your body sees this as like not enough perfusion. So how do we increase perfusion? We make the heart rate go up. We make contractility go up. We make the vessels get smaller, and we increase the volume, or at least stop the loss of volume. So you pee less, you keep the salt, keep the water. Okay. In assessing these patients, look at your differences here. So the left side of the heart is going to back up to the lungs. Okay, so patients that have left ventricular failure, okay, whether it's because of a chronic disease or acutely, right, they're having a big left-sided MI, circumflex, LAD, right, they're going to complain of shortness of breath. They're going to have orthopnea, which is difficulty laying flat. Why? Because there's fluid in their lungs, right? We're upright, gravity-dependent creatures. These patients are going to want to sit up so that they can maximize their breathing. They're going to have paroxysmal nocturnal dyspnea, right? They're going to wake up suddenly, I can't breathe, I can't breathe. They're going to have an increase in respiratory rate, right, because they can't breathe. Probably an increase in heart rate unless they're on some sort of medication that keeps their heart rate low, like a beta blocker or calcium channel blocker. And in their lungs, you're going to see crackle, or you're going to not see it, you're going to hear crackles, okay? So crackles or rails, okay? They may also have pink frothy sputum, okay? But if you're waiting for pink frothy sputum to be your, like, oh, it's heart failure because they have pink frothy sputum, just know in reality we don't see the pink frothy sputum nearly as much as they like to ask you about it on a test. So I would not be waiting for pink frothy sputum. You are way behind at that point, okay? In your right ventricular failure, blood is going to back up to the body, okay? So when you have more fluid in the body, you're going to have weight gain. You're going to have dependent edema. This is why the legs swell. This is why patients who are supine or bedbound get sacral edema, right? They may have ascites, and this is because blood backs up into the hepatic portal vein, right, and into the liver, and so now you have congestion in the liver and fluid that leaks basically from that area. You can have edema everywhere, which is anisacaria, JVD, jugular venous distension, and they may have abdominal pain because of hepatomegaly and enlarged liver or spleen enlargement, because there's all this volume within their vasculature, and it basically causes engorgement of these organs, and so they may complain of abdominal pain, or you may palpate and they have pain with it. All right, for your patients who have heart failure, we want to make sure that we sit them up, okay? We're going to sit them up. We are upright, gravity-dependent creatures. This focuses a lot on left ventricular failure or mixed failure, okay? Because most of the time when we're taking care of these patients, they have a combination of failure, left and right, not just one or the other. But normally when they call us, I can't breathe is their complaint, not my ankle or my ankles are swollen. It's usually I can't breathe. So those patients, we're going to sit them up. We're going to provide for any patient who has crackles in their lungs, non-invasive positive pressure. This could be CPAP or BiPAP, right? If they can't tolerate CPAP or BiPAP, then BVM would be appropriate. We are not going to exert them. Their heart is already weak. Okay, so if we exert them, we're putting more demand on their heart that they can't do. So we're not going to walk them. We're going to give nitrates, okay? So this is like your nitroglycerin. So if a patient has crackles in their lungs and their pressure is good, we might give them a spray of nitro under the tongue, put CPAP on them, and then put paste on them. Please don't remove CPAP to give them more nitro, okay? Put nitro paste on. Your protocol may be to provide diuretics, right? So Lasix or furosemide maybe within your protocol. And then when we're dealing with patients who are in, especially when their pressure is low, right? When we get into like the cardiogenic shock protocol, then we have to do something to improve their pressure. Okay, so a lot of these other, like nitrates, a lot of those patients are usually hypertensive. But if they're in cardiogenic shock, their pressure is terrible, we need to give them an inotrope. What's an inotrope going to do? It's going to increase the force of contraction. This is your dopamine, your dobutamine, your epi, drugs like that are going to increase contractility. And then if they're in acute heart failure because they're in a rhythm, like they're in SVT or VTAC, then if we treat the rhythm, then that acute heart failure is probably going to resolve. So treat the rhythm if that's the problem, okay? Long-term management of an LVAD is going to require, or long-term management of heart failure. When it gets really bad, they often are given an LVAD or left ventricular assisting device. Keep in mind they could have, this could be right or it could be BiVAD where they work on the left and the right. Okay, but what it does, these LVADs are a bridge to transplant. Okay, they're going to need a heart transplant if it gets really, really bad. Okay, so what they do is they act as an artificial ventricle. So there's a pump in there that causes continuous flow, and it's going to consist of the pump itself, the tubing, and then the external battery source, which you can see in this picture. And then an alarm when things are going wrong. So if you're dealing with a patient who has an LVAD, okay, these patients often have no palpable pulse, okay? So if they have no palpable pulse, how do you know they're alive? And the answer is, well, if they're awake and talking to me, right, then they're alive. If they're breathing, they're alive, right? So if we have a patient who's unconscious, we might want to look for other signs of life and reversible causes before we do compressions on these patients, okay? If you have a problem with the LVAD, right, they call you, said, my LVAD's malfunctioning, or, you know, it's alarming or whatever, you want to call their VAD coordinator. They're going to provide you help with treatment, transport, and troubleshooting. And remember, always, always, when you transport, take the batteries. Okay, take the batteries. So this is going to conclude our lecture on heart failure.